I'm Jerald Goldstein. I'm the medical director. I started to practice in 2005, and now we're 3 doctors. We have a 4th doctor joining us in July, and we're based in Dallas, and Frisco is our main facility. We have another office in Dallas proper and in Southlake, but in terms of the IVF occurs in our Frisco facility. Why? There's a lot of clinics to look at. There's a lot of decisions to make. Why would you, what makes us different? I would say that one is that we have a staff that is very, that is used to working with gay couples. And we understand that it is different in terms of the process and in terms of the expense going through. And so we want to make sure that it happens, the first time, and if not the first time, it's certainly the second time. We do last year we did about 550 IVF cycles. We have a very good lab. The lab is a very important part of the component of the process, and it allows us to have excellent success rates. We have an in-house egg donor program. Those are egg donors that we have recruited ourselves, but certainly it's not the same number of donors that, for example, from agencies. You may say you want someone that's, 6'2" and has like an SAT score of 1800. We probably don't have that person, but we screen the donors the same, whether they're our donors, whether they come from an agency. It doesn't matter to me at all. I think it's a matter of really obviously it has to be something that resonates with you. We participate in GPAP through Men Having Babies. And I think that you'll see that from a financial perspective that we are, Texas is a very business-friendly state, and so it's allowed us to do things that are not as expensive as in other states. We do have a multi-cycle plan in terms of patients going through IVF as well as a guaranteed program. We can do that because we feel confident in our success rates, and we also feel like that we're willing to stand, say what we do and do what we say, and so we certainly that's available if that's something that you're interested in, and we're active in terms of in the community as well as through Men Having Babies in terms of helping gay couples. So what happens with your first visit? The first visit really starts with is sitting down and talking to you. The second thing is actually we typically have you freeze sperm. Before we do that, you have to do blood testing that everybody has done, and then that's out of the way. We have you meet our team and also speak to our financial counselor. So I think that you'll find that we don't want things to pop up 6 months later where you're like, well, this is we didn't talk about this or this and that, whatever. It's kind of like that. I think it's very very transparent. And so you would meet with someone, and so it's exactly what the cost is in terms of whether you're using an in-house donor or, for example, one from an agency. Who are the members? Who are the people that are part of your team? Well, obviously the reproductive endocrinologist, or the embryologist, the third party, which is a separate division, so to speak, where you have nurses that basically just deal with people that are using surrogates or egg donors. Because of the amount of information and communication that's required, it's people that's really all they do. Obviously our regular IVF nurses, and then a financial department where somebody would be able to talk to you about that. How do patients come to us? They can either typically start with us, whereby that we would go through and introduce you to like our egg donors, or we can refer you, or they come from like a surrogacy agency. I think that when you talk to surrogacy agencies, you want to find out who, irrespective of like what anybody is telling you here about what their experience is with working with different clinics, and it's the same way when we talk to patients, because it's a group effort, and we don't want to send you someplace where there's going to be an issue down the road, because it's going to affect us, and it's going to make it where that we want it to be successful. Really, the first time. Typically, again, we start off with making embryos, and that's by selecting an egg donor. And then after that, usually in concert with that, then you're also working with a surrogacy agency, picking out a surrogate, so that once we have those embryos created, that we can transfer them into a surrogate and make a baby. Surrogacy agency is involved with making sure the legal part is a very important part, that's usually taken care of by them. Again, I talked a little bit about our in-house egg donors. The advantages, they're pre-screened, no agency fees, are typically local, but also using outside donors. The process, I think, that has already been reviewed before, but basically involves placing women on medications to stimulate their ovaries to produce eggs. The average number of eggs is 17. In our program that we've got from egg donors, the range is anywhere between 10 and 25. Those eggs are aspirated transvaginally under IV sedation after they've taken medication for about 10 days. There's a small little needle that goes to the back of the vaginal cavity, and then we can aspirate the follicles. Those eggs are then fertilized with ICSI. We physically inject the sperm inside of an egg to allow fertilization to occur, and then they're grown in the lab, and this is until day 5, where they're day 5 or day 6, where they're biopsied if you want them to be biopsied for pre-implantation genetic screening, and then they're frozen. Once you have that, we can feel very comfortable about sitting down and saying, okay, how many embryos do each of y'all have if you're doing split insemination? And we feel pretty confident that that's the most important part, because the second part is much simpler and and logistically easier, and that's the transferring the embryos in the surrogate. Or again, they're in the lab for 3 to 5 days. This is our embryologist. You get typically communication in terms of how many eggs we have, how many fertilized, how many eggs make it to day 3, and then how many embryos are biopsied, and then you get a call a week later with the report of how many of those are chromosomally normal. Embryo transfer, usually y'all are intended parents are there, give you a picture of the embryos. Embryo or embryos, I suggest, obviously, recommend a single embryo transfer, but it's a discussion with y'all, and then we usually the intended parents are in the room at the head of the bed, under ultrasound guidance, transfer the embryo, and then 10 days later you do a pregnancy test. What are the things that impact the success? Obviously, egg quality, sperm quality. Egg quality is much more important. The IVF laboratory, cycle monitoring, gestational carriers, which are all pre-screened to have optimal results, as well as embryo transfer. Success rates, we basically do almost exclusively frozen embryo transfers. It's logistically much easier to do that, but in general, between 70 to 80% in terms of transferring for couples using an egg donor and gestational carrier. If y'all certainly welcome to ask any questions. If you have any specific questions, I'm happy to talk to you now or talk to you later, and kind of sit down at it outside. If you have any, just to kind of get to know you, or to sit down, have a consultation. If you have any questions about how we could help you, how you help it make it happen. I know it. Questions? Anything? Uh-huh.
So about the single transfer, and let's say you want an egg for having ultimately have 2 kids.
Mm-hmm.
Now you're thinking about this. Now let's say you want to do a single transfer. How much time, from your standpoint, should we wait after the delivery of the first child? Should we pursue a second child? For the sake of the safety standpoint for the pregnancy itself.
Pardon me?
For the sake of the safety for the child and for the surrogate mother as well.
Well, you're saying transferring the same carrier?
Yeah. So like after the first child is born, and you're willing to have the second child.
Right.
Is there a certain time frame that we should be thinking about? It can't be like next 3 months I can have a child, or
Well, I would say at the minimum 6 months before you're actually, if a carrier delivered and they're coming back in, or or that in terms of ready to go through the process again. Before you actually do a transfer. Sometimes we may see some people before that. It depends. For example, if you're using the same carrier and the carrier for whatever is breastfeeding or things like that, then that delays the time till you actually see them. But at a minimum of 6 months, and up to like a year and a half. But in terms of success, there's really after 6 months, there's really not there's no decrease in terms of success in doing transfer. Other questions? Yes. Oh, okay. So go ahead.
The slides mentioned the guarantee. What's the FST guarantee?
In terms of
Yeah.
70% of what you pay in.
Okay.
In terms of for patients that are going through that are couples that are going through the that are going through the process, then they're guaranteed 70% of the fees that they pay in. If they
After how many attempts or like?
Well, so it depends on what for example, like we have programs that cover like unlimited number of embryo transfers based on, if you have an egg donor, and it covers all, the transfers until you have a baby, beating heart, and a delivery. In a delivery, then we, if you're using an egg donor in gestational care, then we have programs for, that would cover that. But in terms of if you were to go through and you were to, let's say you were to use up all your embryos, for example, and that every one of them miscarried. Let's just say hypothetically every one of them miscarried. Within, you would get 70% of the money back that that you paid in terms of from our perspective. We don't have anything to do with the surrogacy surrogacy agency, and we have so far have not. I mean, obviously, people talk about guaranteed programs, but we've never had to, in terms of using an egg donor gestational care, we've never had to refund anybody because people have gotten pregnant, or we have worked with them in terms of if they've had to use another donor, which has happened, but rarely has happened within. I think that from our perspective, people are more interested in having a baby as opposed to getting money back, because if you get money back, then you're starting all the way back from where you started from. And so, for example, certainly with men having babies, we certainly have had people coming from other programs where they've gone through and they've used multiple, they've gone through all their embryos, and we've almost done it, pro bono, just in terms of making, because ultimately it's what you're interested in is having a baby, not necessarily money to go somewhere else where to go start through the whole process again.
When you talk about fees, what's your overall fees and what's the breakdown?
Well, first thing is, so from a fee perspective, we have people that can talk to you about fees. We have a counselor that can talk to you specifically about that. I think that we're certainly very affordable, but in terms of the specific fees, it depends on whether you're using an in-house egg donor, an agency donor, but all those things are taken into consideration. But certainly if we can, if you call and talk to, actually the slide, here, if you want to take a picture of that slide, you can actually talk to Ashley Gunnarsson, who's our billing person, who would be able to tell you specifically in terms of what programs we do and fees and stuff like that. But I think that we are committed to help to make it happen.
Yeah, so all of this contact information that's on the screen is in your.
Yeah, and here's actually my email information, and if you have any specific questions, I mean there's a lot, and so if you have any specific questions, you're welcome to email me, and I can answer it myself or refer you to someone that can.